pituitary or the hypothalamus. This one, the parathyroid gland, is not controlled by the pituitary or the hypothalamus. It is the free or the ionized calcium, the calcium level or the free calcium level in the blood, which is the controller for parathyroid hormone secretion. Okay, so there is no pituitary, no hypothalamic control. It is the calcium that controls the parathyroid hormone. Normally what happens, decreased levels of free calcium. If there is low calcium in the body, it will increase the synthesis of parathyroid hormone. Similarly, a high calcium will cause decrease of parathyroid hormone by negative feedback. Actions of PTH, what it does mainly, it increases calcium reabsorption, so increases serum calcium, increases reabsorption of calcium from the kidney tubule. So because of which the serum calcium is increased. Then because of this, also it decreases phosphate reabsorption, so increases phosphate excretion, lowering serum phosphate. So it is mainly the increases the reabsorption of calcium, increases calcium and causes phosphate excretion, so lowering phosphate. Okay. Then it has an action on vitamin D. It increases the conversion of vitamin D to its active dihydroxy form in the kidneys. When vitamin D is converted to its active form, the vitamin D does its effect of increasing calcium. And in the GIT, it augments gastrointestinal calcium absorption. The overall effect is to increase plasma ionized calcium and decrease plasma phosphate. Mainly, whenever you find calcium going up, phosphate going down, you think of parathyroid hormone. Prolonged increase of PTH. If there is increase of PTH, in the patient, what will you find? You will find hypocalcemia, hypophosphatemia, and there will be increased alkaline phosphatase level. Why? Because alkaline phosphatase is a bone turnover marker. When there is increased bone breakdown and turnover, alkaline phosphatase will be increased. So similarly, opposite to that, with hypoparathyroidism, there is with hypoparathyroidism, there will be opposite of that, there will be hypocalcemia and hyperphosphatemia. When calcium is going up, phosphorus is going down, think of increased PTH. When calcium is going down, phosphorus is going up, think of decreased PTH. Increased free calcium inhibits PTH secretion by negative feedback. If there is more calcium in the body, it will inhibit PTH by negative feedback. If there is less calcium in the body, it will stimulate the PTH secretion by positive feedback. Now, before we start with the hyperparathyroidism or hypoparathyroidism, I want to tell you about calcium, hypercalcemia mainly. Okay? Now, hypercalcemia can be caused by elevated PTH. We discussed this just now. But hypercalcemia is also a relatively common complication of malignancy. Many of the patients, if you have an older age patient, about 40, 50 years old, and you get hypercalcemia in that, you have to think of malignancy. Nowadays, malignancy is occurring in the younger generation also. So, I will discuss this when there is hypercalcemia with the clinical signs and symptoms. Symptomatic hypercalcemia, it is usually malignancy. Okay? Whereas asymptomatic hypercalcemia, when the calcium levels are just detected on routine blood examination or something, there are no symptoms, then usually that is due to hyperparathyroidism. So you must remember this, that whenever you see a report and you find hypercalcemia, two things you have to look for. Either it is a PTH or there is a malignancy. Now, which malignancies cause hypercalcemia? They can be CA of the lung, breast, head and neck, rectal cancers, hematological malignancies, especially multiple myeloma. Okay, so we did this, that malignancy is the most common cause of clinically apparent hypercalcemia. When there is clinically, there are the signs and symptoms. Clinically, there is hypercalcemia, then it is most probably malignancy. 100% you can't say, but most probably it is malignancy. While if there is asymptomatic elevated blood calcium, incidental hypercalcemia, you just find it nowadays whenever you go for any disease, small disease, to a doctor, first thing they will do the blood tests. And many times they do the serum calcium also. So most of the time, this primary hyperparathyroidism is found incidentally. There are no symptoms of hyperparathyroidism, no symptoms of hypercalcemia, but the patient just goes for a blood test and finds out the calcium levels are high. So that is more commonly due to primary hyperparathyroidism. Okay, and the cause of the malignancy producing hypercalcemia is that these cancers, they secrete a substance which is called PTH related peptide. There is a protein which is secreted by these solid tumors, and this is called PTH related peptide. And this peptide, it binds to the PTH receptors and produces the same biological effects as PTH. PTH is not increased, but the PTH related peptide is increased, which is binding to the PTH receptor and doing the same work as PTH. So PTH causes hypercalcemia, so PTH related peptide also causes hypercalcemia. Okay. Now we come to hyperparathyroidism. Hyperparathyroidism can be primary, secondary, or tertiary. Primary hyperparathyroidism, one of the most common endocrine disorders and is an important cause of hypercalcemia. It is a disease of adults, more commonly in females. 4:1 risk of female having this disease. The most common cause is a solitary parathyroid adenoma arising in the sporadic setting. It's non-familial. Most commonly, it is due to a solitary parathyroid adenoma, single parathyroid adenoma, which is non-familial. It just occurs sporadically. And they are monoclonal in nature. Most of the cases are due to this. But they can also be primary hyperplasia or they can be parathyroid carcinoma. Usually we did this, the hypercalcemia discovered incidentally on a serum electrolyte panel. Now the molecular defects which occur in case of sporadic adenomas are there is cyclin D1 gene inversions leading to overexpression of cyclin D1, a major regulator of the cell cycle, and there are MEN1 gene mutations, which is a tumor suppressor gene. So these are the molecular defects. Now in case of familial hyperparathyroidism, there are genetic syndromes associated with familial parathyroid adenomas, and they include MEN types 1 and 2. This we will discuss, MEN we will discuss in the next lecture tomorrow. And another thing is there is familial hypocalciuric hypercalcemia. What do you mean by that? This is hypocalciuric. That means less calcium is being excreted in the urine. If less calcium is being excreted in the urine, more calcium accumulates in the blood. So there is hypercalcemia due to hypocalciuria. Whatever calcium, extra calcium that needs to be excreted in the urine is not getting excreted and is getting retained, and that is causing hypercalcemia. Why does this occur? There are loss of function mutations in the parathyroid calcium sensing receptor gene. There is a gene which is called the calcium sensing receptor gene. There is mutation in that gene. Because of that mutation, there is loss of function mutation. That means the parathyroid gland is not sensing that calcium. The in the body, there is calcium present in the body, but the PTH receptor is not sensing that calcium. So the PTH thinks that there is low calcium, so it starts producing more parathyroid hormone. So there's a loss of function mutation in the parathyroid calcium sensing receptor gene, because of which there is decreased sensitivity to extracellular calcium. Whatever extracellular calcium is there, it is not recognized. When it is not recognized, the parathyroid gland thinks that the calcium levels are low and starts to hypersecrete the parathyroid hormone, which leads to hypercalcemia. Any question, any query, please ask me. On chat, you can unmute your mics. You can ask me at any point of my lecture. Have you all understood this? Calcium sensing, loss of function mutation of calcium sensing receptor? Everyone? No questions? Okay. Clinical cause. Primary hyperparathyroidism may be asymptomatic or symptomatic. Asymptomatic asymptomatic hyperparathyroidism, because calcium levels are routinely analyzed, clinically silent hyperparathyroidism is often detected early. There are no symptoms, clinically there is nothing, but the calcium it is detected on routine blood tests. Classical manifestations are now infrequently seen. So, because the patient is diagnosed early, the classical manifestations may not be seen. And primary hyperparathyroidism is the most common cause of asymptomatic hypercalcemia. And malignancy is the most common cause of clinically apparent hypercalcemia in adults and must be excluded. If you find hypercalcemia in the body, see if there is symptomatic or asymptomatic. If it is symptomatic, older age patient, more chance of malignancy. If it is asymptomatic, still it is a disease of adults, but lesser age, so it can be, but it is asymptomatic, then it is most likely primary hyperparathyroidism. Lab findings, we have hypercalcemia and hypophosphatemia, right? We did this. Elevated serum PTH levels, inappropriately raised levels in the presence of hypercalcemia. Now, in a normal patient, you and in me, if the calcium level is high, the PTH should be very, very low, right? If the PTH is high, PTH may also be low normal, high normal also. But in a normal patient with that high calcium, the PTH should be very low. This you keep in mind. If the PTH is not low, PTH is high normal, or PTH is abnormal, that means it is due to increased PTH level. That is hyperparathyroidism. You understand this? Hypercalcemia, normal people, they will suppress the PTH. PTH will be very, very low. But if the PTH is not low, it is maybe normal, normal high, high, then it is due to elevated PTH. There is hyperparathyroidism. Okay? Have you all understood this? Okay. There is increased urinary excretion of both calcium and phosphate. High plasma, see, we discussed this before that PTH causes retention of calcium. It does cause retention of calcium. It causes the hypercalcemia, and then because of the hypercalcemia, a lot of calcium in the body, it starts excreting calcium also. So there is increased urinary excretion of calcium and phosphate. Calcium and phosphate excretion is there, but the blood calcium is still high. Okay. Then there is high plasma alkaline phosphatase activity. We did discuss this. Now, there are radioimmunoassays specific for PTH and PTH receptor protein are available and can distinguish primary hyperparathyroidism and malignancy associated hypercalcemia. So, there are certain assays, there are certain tests which will differentiate if the patient has got PTH or patient has got PTH PTH related peptide. So you can diagnose if the patient is suffering from primary hyperparathyroidism or the patient is suffering from malignancy associated hypercalcemia. Symptomatic primary hyperparathyroidism. Primary hyperparathyroidism is associated with painful bones, renal stones, abdominal groans, and psychic moans. There is bone disease and bone pain secondary to fractures of the bones weakened by osteoporosis. Now, to maintain the hypercalcemia, the bone also, the PTH takes up calcium from the bones. So, bone becomes weak. There is osteoporosis and osteitis fibrosa cystica. Due to the weakened bones, there is bone pain, bone fractures. Then, nephrolithiasis, a lot of calcium being excreted in the urine. So, this calcium precipitates in the form of renal stones, causing pain and obstructive uropathy. Okay. Chronic renal insufficiency and abnormalities in renal function lead to polyuria and polydipsia. Gastrointestinal disturbances, there is constipation, nausea, peptic ulcers, pancreatitis, gallstones. CNS alterations, there is depression, lethargy, and eventually seizures. Neuromuscular abnormalities, weakness and fatigue. Cardiac manifestations, aortic or mitral valve calcifications are present. So these symptoms, these are a mixture of symptoms. The hyperparathyroidism causes nephrolithiasis and bone disease, whereas the hypercalcemia, the manifestations of hypercalcemia are fatigue, weakness, pancreatitis, metastatic calcifications, constipation, all these things are due to hypercalcemia. Hyperparathyroidism just causes nephrolithiasis and bone disease. Okay. Now we come to secondary hyperparathyroidism. Any condition that gives rise to chronic hypocalcemia, which in turn leads to compensatory overactivity of the parathyroid gland. When we did the other endocrine disorders, primary was remember always that in endocrinology, any disease primary means the gland which is producing the disease is abnormal, right? That is primary. Secondary, something other than the gland. So here there is no pituitary to have for secondary disease. So what is mainly the cause of secondary hyperparathyroidism? Hypocalcemia. Any condition which gives rise to hypocalcemia will stimulate the parathyroid and will cause secondary hyperparathyroidism. The most common cause of this is chronic renal failure, right? Many patients I have seen in my experience, most of the patients with increased PTH are due to renal failure, right? It can also be caused by inadequate dietary intake of calcium, steatoria, and vitamin D deficiency. This is there in your books, but I have not seen vitamin D deficiency causing secondary hyperparathyroidism. Chronic renal insufficiency causes decreased excretion of phosphorus, leading to hyperphosphatemia. Now, renal insufficiency is there, kidney is not functioning, this decreased excretion of phosphorus. Phosphorus is retained and there is hyperphosphatemia. The elevated phosphorus depresses calcium levels and stimulates PTH. Due to the elevated phosphorus, the calcium is depressed and PTH is stimulated. Also, loss of renal substance reduces the availability of 1-alpha hydroxylase, which is necessary for the synthesis of the active form of vitamin D. 1-alpha hydroxylase, the work of 1-alpha hydroxylase is to activate vitamin D. So, loss of renal substance reduces the availability of 1-alpha hydroxylase. So, vitamin D is not converted to the active form and there is decreased intestinal absorption of calcium, both causing reduced ionized calcium. So, intestinal absorption of calcium is also blocked. Vitamin D also has suppressive effects on PTH secretion. Its relative deficiency compounds the hyperparathyroidism in renal failure. So, vitamin D itself also inhibits PTH secretion. Right? Now, I don't know if you have discussed, if you have studied vitamin D separately in some with some topic, but vitamin D nowadays vitamins are supposed to be something which are needed in very small quantities and whose deficiency cause disease, right? But vitamin D is now not considered to be a vitamin; it is more of a hormone. It's, its name, I think, shortly should be changed to hormone D because it is hormone is something which is essential for life. Vitamin D is vitamin D deficiency is very common in the world, all over the world. In Pakistan, all over the world. We think in Pakistan that because we have a sunny climate, we don't have vitamin D deficiency. But we do, because how much sun do we get the whole day? You have to get the sun from 11 a.m. to 3 p.m. How much sun? I don't go in the sun at that time. No one, most of us don't go. So we don't get that vitamin D. We don't get that sunlight to produce vitamin D. So many of us, even in Pakistan, all over the world, there's vitamin D deficiency. And vitamin D is now considered to be, I told you, it's now thought to be a hormone, and it is implicated, the deficiency is implicated in cancers, in many diseases, even in COVID nowadays, which is coming up, which is also vitamin D will increase the person to get infected and more complications of COVID because of vitamin D deficiency. So vitamin D has a role in many of the diseases in our body. Okay. Now, so secondary hyperparathyroidism is a physiological response of the parathyroid gland to hypocalcemia. Right? Secondary hyperparathyroidism is not a pathological process. Basically, it is a physiological response to hypocalcemia. Whenever our body has hypocalcemia due to any cause, the parathyroid hormone gets stimulated. Physiological response on the parathyroid hormone is normal. It will start producing more, and it will cause, because of the increased PTH, it will bring the calcium back to normal. So in this condition, serum calcium is usually normal. So remember this, that in primary, the calcium is raised, the PTH is raised. In secondary, PTH will be raised, calcium will be normal, right? And in tertiary, again, the PTH and the calcium will be raised. Clinical course of secondary hyperparathyroidism usually dominated by symptoms of chronic renal failure. I told you most of the cases of secondary hyperparathyroidism are due to renal failure. Bone abnormalities, renal osteodystrophy and other changes are usually less severe than those seen in primary hyperparathyroidism. Now, see, these changes are secondary hyperparathyroidism are everything, all the changes are less severe. There can be calciphylaxis. What is that? Vascular calcifications may occur resulting in severe ischemic damage to the skin and other organs. There is calcification of the blood vessels, so there can be ischemic damage to the skin and other organs of the body. Tertiary hyperparathyroidism. Now what happens is the patient has chronic renal failure, patient starts excreting calcium, hypocalcemia. Because of the hypocalcemia, the PTH, the parathyroid gland, starts overproduction and it maintains the calcium back to normal. Now, long-standing cases of renal failure, what happens is that the parathyroid gland is so used to hyperfunctioning that it becomes autonomous. It starts secreting, it doesn't look at the calcium, it keeps on secreting more and more PTH. So, because of this, now this gland itself has become overactive, irrespective of the PTH levels. So now it causes hypercalcemia. So when the long-standing cases of renal failure, PTH becomes autonomous, excessively secreting the hormone, then which results in hypercalcemia. It is not the hypercalcemia is not bringing the PTH to normal. So there is hypercalcemia, there is increased PTH. This is called tertiary hyperparathyroidism. Primary, the gland itself is functioning excessively. Secondary, physiological response to hypocalcemia. Tertiary, gland becomes autonomous. Long-standing hypocalcemia, gland starts doing its own work. I don't care about calcium, I don't care. I'm going to keep on working. So excessive secretion of PTH, which results in hypercalcemia again. So primary has got hypercalcemia, increased PTH. Secondary has got increased PTH, normocalcemia. Calcium levels normal. Tertiary has increased PTH, increased calcium. Okay. Treatment of this is parathyroidectomy may be necessary. Any query with this? Please write in the chat if you have any problem with the parathyroid hyperparathyroidism. No? Okay. Now we come to hypoparathyroidism. Causes of hypoparathyroidism, most common cause is surgically induced hypoparathyroidism. Patient is there's a thyroidectomy going on. Is being treated for some thyroid disease. The thyroid gland is being removed. Because the parathyroid glands are tiny glands present behind the thyroid, they may be removed accidentally. Or in other neck surgeries, they may be removed, or sometimes they are mistaken for lymph nodes. They are tiny nodes, they may be mistaken for lymph nodes. So they are accidentally removed. Then autoimmune hyperparathyroidism, this is often associated with chronic mucocutaneous candidiasis and primary adrenal insufficiency, and this syndrome is called autoimmune polyendocrine syndrome type 1. This is autoimmune. Then autosomal dominant hypoparathyroidism. This is caused by gain of function mutation in the calcium sensing receptor gene. At that time, we had got a loss of function mutation. In hyperparathyroidism, there was loss of function mutation. Now, this is a gain of function mutation. The same gene, calcium sensing receptor gene, there is a mutation because of which there is a gain of function. So, what happens? The parathyroid gland senses that there is a lot of calcium in the body. So, it starts secreting less and causes hypoparathyroidism. Right? Because of the hypoparathyroidism, there is hypocalcemia and hypercalciuria. Okay. Familial isolated hypoparathyroidism and can be autosomal dominant or autosomal recessive, or there can be congenital absence of the parathyroid gland. It can occur in conjunction with other malformations like thymic aplasia and cardiovascular defects, and this is called Di-George syndrome. Clinical manifestations are related to the severity and the chronicity of hypocalcemia. Hallmark of hypocalcemia is tetany, which is characterized by neuromuscular irritability resulting from decreased serum ionized calcium levels. There can be numbness or paresthesia, tingling of the distal extremities, and carpopudal spasm to life-threatening laryngospasm and generalized seizures. Neuromuscular excitability, tetany. Hallmark of hypocalcemia. Positive Shostak sign seen in subclinical disease. If you tap along the course of the facial nerve, there is contractions of the muscles of the eye, the mouth, the nose. Positive Trousseau sign, if you take the blood pressure cuff, if you occlude the blood vessel with the blood pressure cuff for a few minutes, it will cause spasm of the carpal spasm. Okay. Then mental status changes, anxiety, depression, confusion, hallucinations, and psychosis. Intracranial manifestations, calcification of the basal ganglia, Parkinsonian-like movement disorders, and increased intracranial pressure with resultant papilledema. Hypocalcemia with calcifications may be due to an increase in phosphate resulting in tissue deposits. You may think that if there is hypocalcemia, how does it deposit? How does calcium deposit in the tissues? The hypocalcemia doesn't do it. The hyperphosphatemia, that pulls the calcium and causes the deposition in the tissues. Okay. There is calcification of the lens and cataract formation. Cardiovascular manifestations, characteristic blockation of the QT interval on the ECG. Dental abnormalities, if there is hypocalcemia during early development, during the development of the teeth, there can be dental hypoplasia, failure of eruption, defective enamel, root formation, and abraded caries teeth. Then there is a condition which is called pseudo-hypoparathyroidism. Pseudo means false. In this condition, hypoparathyroidism occurs due to end organ resistance to the actions of PTH. PTH is present, but the organs which are on which PTH is acting, there is resistance to PTH. So in this, you have PTH may be normal or elevated, and it presents as hypocalcemia, hyperphosphatemia, and elevated circulating PTH. It may also be accompanied by resistance to TSH, FSH, and LH. And TSH resistance is mild, but FSH and LH resistance can cause hypergonadotrophic hypogonadism in females. That's it for the parathyroid. Any query for parathyroid, please ask me. Any query? No? Okay, now because the adrenal gland, I have just got one lecture for the adrenal gland and it was quite a long lecture. So I have brought Cushing syndrome into this with this topic with the parathyroid, and the rest of the adrenal I will cover in my next lecture tomorrow. So we come to Cushing's, just a brief preview about the adrenals. Adrenal glands are paired endocrine organs consisting of both cortex and medulla. Adrenal cortex is made of 3 zones. Now, I remember this by GFR, glomerulosa, fasciculator, reticularis. Outermost is G, outer to inner if you go is GFR, glomerulosa, fasciculator, reticularis. Inner side is the adrenal medulla composed of chromatin cells. The hormones of the adrenal cortex, they are mainly glucocorticoids, principally cortisol, which are synthesized in the zona fasciculator and a lesser degree in the zona reticularis. Mineralocorticoids, the most important of which is aldosterone, generated in the glomerulosa, and sex steroids, estrogens and androgens, which are produced largely in the zona reticularis. Adrenal medulla synthesizes catecholamines, mainly epinephrine. Now we come to adrenocortical hyperfunction. There are 3 distinctive hyperadrenal syndromes. One is Cushing syndrome, characterized by excess of cortisol. One is hyperaldosteronism, excess aldosterone. Then third is adrenogenital or virilizing syndromes caused by increase of androgens, increase of cortisol, increase of aldosterone, increase of androgens. The clinical features may show some overlap because of the overlapping functions of the steroids. Now we come to Cushing syndrome. This disease is caused by any condition that produces elevated glucocorticoid levels. It can be broadly classified into exogenous and endogenous causes. Now, mainly, the most of the cases of Cushing syndrome are due to administration of exogenous glucocorticoids. What do you mean by exogenous? Corticosteroids taken from outside, and in the form of tablets, in the form of medicine, in the form of some other, these homeopathic medicines, they are filled with glucocorticoids. I have seen Cushing syndrome in small babies. How? They appear to be very chubby and nice and fat and but they are suffering from Cushing's. Why? Because the mother is using nappy rash cream. The nappy rash cream contains steroids. So I have seen Cushing's in these small babies also. So with such a small baby, even topical steroid is enough to cause Cushing's. So most of the cases of Cushing's are due to exogenous administration of glucocorticoids, and this is called iatrogenic Cushing's. The endogenous causes can be divided into ACTH dependent and ACTH independent. Now, I told when we were discussing the pituitary, I told you something, there are two things, Cushing syndrome and Cushing disease. If you remember, we have discussed thyrotoxicosis and hyperthyroidism. Increased symptoms, the symptoms of that hyperthyroidism, the symptoms of thyrotoxicosis, if the symptoms are there, it is thyrotoxicosis. If the symptoms are due to increased secretion by the thyroid gland, it is hyperthyroidism. Similarly, if the symptom complexes are there, if there is the symptom complex is due to high cortisol, we will come to the symptoms. If the symptom complexes are there, that means the patient has got Cushing syndrome, right? If the Cushing syndrome is due to excessive production of ACTH by the pituitary, here the most important cause and the most common cause is ACTH excess, not adrenal corticosteroid excess. If the Cushing syndrome, the signs and symptoms are due to increased production of ACTH by the pituitary, then it is called Cushing disease. So this is the difference between Cushing syndrome and Cushing's disease. If you have not understood, anyone, you can please ask me on your chat or on your mic. Okay? I have not received any query. All right. That means you have understood. Now, ACTH secreting pituitary adenomas. This accounts for 70% of cases of endogenous hypercortisolism. Most of the cases I told you, it is not due to the adrenal overfunctioning, it is due to the pituitary overfunctioning and producing lots of ACTH. Frequently affects young women, adult women. Majority of cases it is caused by ACTH producing pituitary adenoma, which can be a microadenoma or a macroadenoma. Most commonly, microadenomas are more common, macroadenomas in some cases, and in few cases there can also be cortical hyperplasia, which can be primary or arising secondarily from increased ACTH or CRH producing tumor. Now, in Cushing's disease, there is nodular cortical hyperplasia of the adrenal glands. Now, Cushing disease is pituitary excess. ACTH, if it is producing a lot of ACTH, pituitary producing lots of ACTH, it will go and affect the adrenals. Adrenal, there will be nodular cortical hyperplasia of the adrenals because of that ACTH coming from out, right? And there is cortical hyperplasia of the ACTH of the adrenals, and this is responsible for the hypercortisolism. Sometimes there is ectopic ACTH production, secretion of ectopic ACTH by a non-pituitary tumor. Sometimes certain tumors, like small cell carcinoma of the lung, it can cause secretion of ectopic ACTH. And this is also an ACTH dependent pituitary Cushing's, but this is not Cushing's disease. It is Cushing syndrome. Cushing disease is only when the pituitary is secreting excess ACTH, and it is called ACTH. It is called Cushing's disease. When the ACTH is coming from anywhere else, or the cortisol is being secreted directly by the adrenal, it is called Cushing syndrome. Other tumors which can cause ectopic ACTH are carcinoids, medullary carcinoma of the thyroid, and islet cell tumors. Primary adrenal neoplasms, adrenal adenoma, and carcinoma are the most common causes of ACTH independent Cushing syndrome. Now, if it is not dependent on ACTH, it is the adrenal which is doing it, then it can be an adrenal adenoma or it can be an adrenal carcinoma. Patient shows high serum levels of cortisol with low levels of ACTH. अगर पिट्यूटरी ओवर एक्टिविटी कर रहा है तो increase ACTH, increase cortisol. अगर adrenal खुद कर रहा है, adrenal itself is doing it, then the cortisol will be increased and the ACTH will be low because it will be inhibited by negative feedback. So here you find high cortisol and low ACTH. Cortical carcinomas tend to produce more marked hypercortisolism than adenomas or hyperplasia. So carcinomas more marked. In unilateral carcinoma, the uninvolved adrenal cortex undergoes atrophy due to decreased ACTH secretion. Now, supposing there is a carcinoma, usually carcinoma is unilateral, one adrenal has carcinoma, the other adrenal, because it will undergo atrophy because of that one tumor inhibiting ACTH, so it will the low ACTH will inhibit the other adrenal, the normal adrenal, and there will be atrophy of that other adrenal gland. ACTH dependent hyperplastic adrenals. Majority of the hyperplastic adrenals are ACTH dependent. In macronodular hyperplasia, the nodules are usually greater than 3 millimeters in diameter. Okay, micronodular less than 3, macronodular greater than 6. The morphological features in this case is there is exogenous steroid-induced disease. That in exogenous steroid-induced disease, there is bilateral cortical atrophy. If the patient is taking steroid from outside, ACTH will be reduced, the adrenals will be atrophied, both of them. In endogenous Cushing syndrome, there is bilateral diffuse or nodular hyperplasia. Endogenous, then there is diffuse or bilateral diffuse or nodular hyperplasia, and also thirdly there can be adrenal neoplasm. Clinical features of this disease: early stages, the patient may present with hypertension and weight gain. Just no symptoms, weight gain and hypertension. There is a characteristic central pattern of adipose tissue deposition in the form of truncal obesity. When we used to study, there was a saying, lemon on a stick. The patient is like a lemon and the hands and legs are like sticks. So the central pattern of obesity, the face is large and round, the abdomen is large and round, hands and feet are very, very thin. Right? There is moon facies, face appears like a moon, rounded, accumulation of fat in the posterior neck and back, buffalo hump. Over here, the back, there is a hump. Atrophy of the muscles causes decreased muscle mass and proximal limb weakness. Glucocorticoids induce gluconeogenesis and inhibit the uptake of glucose by the cells, with resultant hyperglycemia, glucosuria, and polydipsia, and this is called secondary diabetes. Cause of Cushing's, there can be hyperglycemia and secondary diabetes. The skin is thin and fragile and easily bruised. Wound healing is poor. Cutaneous striae are seen in the abdominal area. We discussed this before. Cutaneous striae, increase of ACTH. When there is increased ACTH, there will be cutaneous striae in the abdomen. Bone resorption results in the development of osteoporosis, which with increased susceptibility to fractures and backache. The immune response is suppressed, leading to increased risk of infections. Mental disturbances, mood swings, depression, and frank psychosis. There can be hirsutism and menstrual abnormalities in the female. Now, one very important cause of hirsutism is Cushing's. There are one or two other diseases, but many of the patients with Cushing's, they present with hirsutism. Female having facial hair, like beard hair, she is very wild, and that is one of the early signs in which the patient comes to you. Menstrual abnormalities are also there, but she may not understand. But the hirsutism is very common. The facial hair growth in the female, that may be the presenting feature. Patient may come to the doctor with that. Doctor साहब मेरे face पे बाल उगने लगे, but ठीक है. So this is common. See, this is a picture of patient with Cushing's. Red cheeks. This is the buffalo hump at the back. The bruises on the hands and the legs. See the abdomen, the stretch marks. See the large round thorax and abdomen. The abdominal stretch marks are this is the typical pattern of the stretch marks. Pendulous abdomen, thin arms and legs. See, this is the typical pattern of the abdominal stride in Cushing's. Even in Addison's it will be there, but I will tell you later. Lab diagnosis, first line tests. See, Cushing syndrome, you are suspecting that you're suspecting a patient of having Cushing syndrome. That means you are suspecting that the patient will have increased cortisol. I told you before that cortisol, high levels of cortisol is a diurnal pattern of the secretion. Early morning there is maximum cortisol, late night there is minimum cortisol. So here, if you are suspecting that the patient has got Cushing's, you want to take the cortisol, blood for cortisol when you feel that there is a lowest level of cortisol is there, right? So lowest levels of cortisol are seen in case of late night salivary cortisol, saliva, you take saliva sample, or you can do a 24-hour urinary free cortisol. These are three first line tests for cortisol. You can take the 24-hour urine sample and test it for cortisol, or you do a 1 milligram overnight dexamethasone suppression test. This in the books. These are the three important primary first line tests for cortisol. What you do is you give the patient 1 milligram dexamethasone. This is a steroid tablet which is given in the night to the patient, which is supposed to suppress the cortisol. Right? So in the morning when you take the blood for cortisol levels, the cortisol in a normal patient it will be suppressed. If the cortisol is not suppressed, that means there is loss of control and there is Cushing's. At least 2 first line tests should be abnormal to diagnose Cushing syndrome. There is loss of the diurnal variation of cortisol secretion. I told you there is a diurnal variation. Early morning cortisol is the maximum. Late night cortisol is the minimum. There is loss of the diurnal variation. I told you many times. Loss of control means there is a problem with the gland. How do you do a dexamethasone suppression test? Dexamethasone is a synthetic glucocorticoid which can suppress ACTH release. 1 milligram of dexamethasone given at night. Cortisol is estimated at 8 AM. Cortisol level not suppressed. Patient is suffering from Cushing syndrome. In pituitary Cushing syndrome, ACTH levels are elevated and cannot be suppressed by the administration of low dose of dexamethasone. If the pituitary is hyperfunctioning, lot of ACTH being produced, you give low dose of dexamethasone, it will not suppress the dexamethasone. So it will not suppress the cortisol. So no reduction in urinary excretion of 17-hydroxycorticosteroids. This is the one of the metabolic things in the pathway of cortisol production. After giving high doses of injected dexa, the pituitary responds by reducing ACTH secretion, seen by the suppression of urinary steroid secretion. Now, if you give a larger dose of injected dexa, then the ACTH can become suppressed. May or may not, but can. In ectopic ACTH secretion, if there is secretion by some other tissue, there will be no any dexamethasone will not suppress this. Okay? So secretion is insensitive to low or high doses of exogenous dexa. If you give low doses of dexa, high doses of dexa, pituitary can become suppressed. But in ectopic ACTH, pituitary will not become suppressed even if you give high doses or low doses of dexa. In Cushing syndrome caused by adrenal tumor, if there is adrenal problem, there is no ACTH level. Now ACTH is already low. Okay? So if you give dexa, there is no suppression of cortisol. So this is how you diagnose that which type of